Welcome to AETCM, the Emergency Medicine Channel. Good morning, sir. Today we will be talking about a case which came with shortness of breath to the emergency. A 78-year-old male has been rolled into the ER with shortness of breath. Initially, the triage officer has assorted the case, has seen the case and took the initial vitals wise. The respiratory rate was 35 and systolic blood pressure was noted to be 220 and GCS was 15. So as per the adult triage sort, the patient has been given respiratory score of 3, systolic blood pressure score of 4 and GCS score of 4. So the total score was 11 and the patient was sorted as priority 2, that is yellow category, and the patient was brought into the yellow bed.
Okay.
Now, on arrival on the first primary assessment, the patient's airway, starting with the airway part, patient was having difficulty to complete the whole sentence. He was not able to complete, he was having difficulty to complete the whole sentence. There were no secretions in the oral cavity and there was no any added sounds like stridor. At this point of time, because of the difficulty to completing sentence, we put on
So what is the problem vocalizing?
He was able to vocalize the sentence, but he was unable to use the breath to complete the whole sentence. So suspecting because of his shortness of that breath, we started with an oxygen via face mask.
So propped him
up, head.
Any shortness of breath?
First head end to be propped up to 45 degrees.
Okay.
And
then keep
O2 mask. Next, coming to the breathing, the patient's respiratory rate was 35 and saturation was 88% without oxygen mask, after which the oxygen mask was put.
Okay.
And patient on inspection wise, patient was using accessory muscles for respiration, and the trachea was central in position. On palpation, trachea was central in position. On auscultation, breath sounds were equal in both the lungs.
No, like in inspection, you'll have to inspect the neck, see if the trachea is central. Inspection,
the trachea
and
was
whether move to the chest, see if the excursion of the chest is normal or not. Any abnormalities, any asymmetry or anything is there or not.
Equal rise in both bilateral side.
No injuries, nothing is there. Okay, equal. Appears equal. Okay.
Then palpation. Trachea is central in position and
palpated trachea is central. Okay.
And the chest rise on palpatory method also was equal bilaterally, and the AP diameter was more than the lateral. Chest was expanded.
One more thing, in the inspection of the neck, you'll have to see for the dilated neck veins also.
Yes.
Okay. Because in a case of breathlessness, you're basically concerned about pneumothorax, pulmonary embolism, then pulmonary edema, COPD exacerbation, bronchial asthma exacerbation, pneumonia. All these are your
primary
priorities. Like, okay. So, if there is tension in pneumothorax, or even if there is a cardiac tamponade or anything, neck veins will be dilated. Yes. So that should be covered in inspection itself. When you look for when you assess the B of your ABC, inspection itself you assess that. Then go down. Okay. Then inspection, then palpation.
Trachea is central in position and the chest rise in palpatory method also is equal bilaterally. And after that, auscultation. Percussion.
Yeah.
Resonant sound on bilateral side. There is no any dull note on the.
Resonant means you need to say percussion, resonant, equal bilaterally. That's all.
Yes.
Okay. No need to say there is no dullness. Once you have told it's resonant, means it's resonant. Okay. It's not hyper-resonant, right? Not hyper-resonant. Okay. Then auscultation.
In auscultation wise, bilateral creps were audible.
So air entry is bilaterally
equal and creps were whole full creps were present. Completely creps were present.
Okay.
So
respiratory RR right now is what?
Tachypneic 35
and
saturation was 88%.
So kept on O2, and did the saturation improve by that time?
With 4 liter oxygen saturation, 6 liter oxygen, the saturation increased from 88 to 97.
6 liter oxygen, 88 to 97. Okay.
And next, coming to the circulatory system.
Ideally, if you are writing the MRCOM exam and all, especially OSCE exam and all, once you feel the airway is patent, straight away you apply NRBM with high flow oxygen.
Okay.
That is what they suggest, especially if you are writing the MRCOM OSCE exam for the exam purpose.
Yes, sir.
Airway patent, keep high flow NRBM with high flow O2, then move to B, assess B completely. Okay, and then and there itself, if the respiratory rate is high or so, and if you think it requires BiPAP or intubation at that point of time, you can keep a BiPAP also. At that point B itself, we can start on BiPAP because the respiratory rate is high.
Creps were also.
So at that point itself, to reduce the work of breathing,
Yes, sir.
you can place a BiPAP.
Then coming to the circulation, pulse rate was 86 per minute and BP was 220 by 110. And peripheral, all the peripheral pulses were palpable.
CRT.
See, capillary refill time
Basically,
was
heart rate. It's not pulse rate. Heart rate is what? Heart rate, BP, and CRT. That is what we are interested in.
CRT is less than 2 seconds.
Less than 2 seconds. BP is on the higher side.
Higher side.
And heart rate how much?
Heart rate 86 per minute.
86. Okay. 220 something. No? BP.
Yes, sir. BP 220 by 110.
Okay. So at that point, connect all the monitors.
At this point, we connected to the cardiac monitor. At the same time, 2 IV large bore IV cannulas.
2 large bore IV cannulas you can place, and you can draw
samples and send for the ABG and lab.
ABG, hematology, biochemistry, blood cultures, all these even blood cultures, everything you can draw at that point itself.
Yes,
Okay. So you don't because BP is on the higher side already. Right now, I don't think it is safe to administer an antihypertensive drug at this point of time because we don't know the background history.
yes.
Okay, so let's move to
D.
the D.
Disability.
And also in C itself, we'll have to auscultate for the heart sounds. S1, S2
is heard.
Heard or not?
S1, S2 is heard.
Any murmur, nothing.
No added sounds.
Okay.
Then D, disability. So GCS was E4, V5, M6. Patient was completely conscious
GRBS, first
oriented.
GRBS, then GCS, then pupils.
Okay. First GRBS. Patient's GRBS was 186 mg per DL. And then pupils were bilateral. GCS. GCS is E4, V5, M6. Patient was conscious oriented. And then pupils were 2.5 mm bilaterally reactive to light. And then coming to E, exposure.
Lateralizing signs, especially that is for trauma cases. Ask him to move out all the limbs, just quickly check for all the sensations and all these things. No lateralizing signs. Then exposure.
Patient was febrile and exposure, but no any external injuries.
No, that is for trauma case. In this patient is any rash because sepsis and all, no, you may get rash and all. Any rash is there or not? What is the temperature? What is it cold, clammy? Because talking about shortness of breath, so you're expecting pulmonary edema, pulmonary embolism, all these things. So pulmonary edema and all usually it should be cold and clammy. But if it is a sepsis and things,
bilateral pedal edema can be seen in exposure.
Pedal edema.
Generalized
edema not there. It's not an exposure. So basically, you look for looking for shock.
No.
Any rash or anything is there or not. Basically for sepsis, looking for sepsis. And if the patient is in shock or what is about? Is it cold, clammy extremities? Is it warm? Warm means suggests more like a to sepsis. Cold, clammy is pulmonary edema. Okay. So that's about exposure. So this is fine.
Exposure.
Was it warm or
This was warm.
warm?
Warm. No shock.
Okay.
BP was 220.
BP was 220.
The only findings right now, we have BP of 220 and respiratory rate of tachypnic. He was tachypnic, hypoxic, and patient was having
On the
bilateral
background of
cramps.
this thing, actually like shortness of breath on a background of this much of 220
BP.
BP, most likely like a pulmonary edema secondary to accelerated hypertension. But one thing which goes against this is warm peripheries. Normally it will be cold clammy and all, that is what we expect. Not febrile also, nothing. Okay. So that's about your
Primary survey.
primary survey. Okay. So right now I think the patient is fairly stable. You put him on BiPAP, this patient is fairly stable. And
You have
what
to
about
put him on BiPAP now, as the
On
tachypnic on reassessment, the patient's respiratory rate has still been 30. It did not reduce from.
okay?
So we can, as the patient,
In spite of BiPAP, respiratory did not.
in spite of oxygen of 6 liter oxygen, this patient did not, the tachypnea did not reduce.
Okay.
So we can consider first to put him on a trial of BiPAP.
BiPAP, I think in B itself we have placed, no?
B we put the oxygen. Yes.
Oxygen B itself, no? Oxygen you kept in A.
Yeah. Okay.
And now with high flow O2. Then in B probably.
Because of the use of accessory muscles and
and all,
tachypnea, we can start on BiPAP and B
BiPAP.
itself.
Right now, like this is not the practical approach. This is for the purpose of MRCOM OSCE
Yes.
exam purpose. I'm telling.
Yes, sir.
Okay. So BiPAP we have placed. And what about on reassessment of ABCD? Did all these things resolve?
No, this BP is still high. We didn't
BP,
actually.
airway is still patent.
Airway is still
These-
patent and tachypnic is there, but saturation is improved with the.
BiPAP.
Yes. Sir.
Okay.
And sorry, tachypnic also has improved with the BiPAP.
All right.
But BP is still high, for which we can, as the IV cannulas are already in place, we can give one sort of injection furosemide diuretics. We can start
Diuretics. Okay.
to initially, because patient was having creps.
All right. So more likely, based on your primary survey, you feel it's more like a pulmonary, acute pulmonary edema.
With cardiac cause because of high BP.
The precipitating thing is accelerated hypertension.
Accelerated hypertension.
Okay. What about the ABG values? By that
The adjuncts to primary survey with the ABG
because in C itself we have drawn the
samples.
blood gas samples, ABG and yeah.
There was no acid-base disorder, and lactate was to the higher side of 2.
Okay. Some anaerobic activities.
The high use of accessory muscles for the
going on. So only lactate 2. Other things are.
electrolytes are all in the normal ranges. 4
Because
potassium.
with this thing, shortness of breath and all, you'll actually like expect something more, right? A normal ABG, it's not usually seen. Something like either hyperventilating or either metabolic acidosis, something should be there. But this one, it was
It was normal.
So you gave Lasix at that point of.
First step was to put on the BiPAP, and second to give Lasix injection, and the next to go with the secondary survey and then assess the BP
Okay.
to
So now we can move on to the secondary survey.
ample.
Ah.
Patient has no allergy to any previous.
Okay, so let us expand it further. Like, basically came with shortness of breath. So elaborate on the shortness of breath.
Shortness of breath. Patient has no
Patient, going according to ample history or
ample.
ample? Okay, then go according to that.
Ample. First allergy. Talking about the allergy, the patient has no any previous allergies to any known medication. Second, the medications he was on, he was being treated. The known case of he's a known case of CAD. He has a triple vessel disease in 2009, status post CABG, and he is a known case of systemic hypertension with concentric LVH, type 2 diabetes mellitus, status post cholecystectomy, status post right inguinal hernia repair, status post bilateral cataract surgeries, and he was having moderate asthma with mild renal dysfunction and left shoulder discomfort. These are all his known cases.
So basically CAD post CABG. In that case itself, you will expect his ejection fraction should be
Lower
a bit
and-
on the lower side. So
We have the last echo report showing moderate LV dysfunction.
moderate LV dysfunction. So is it very high chance of going into pulmonary edema? Maybe because of other factors such as anemia, accelerated hypertension, even sepsis. Anything can even thyrotoxicosis. Okay, so that is one, or a new ACS itself,
Yes.
or a mitral valve rupture, MR. All these things can cause a pulmonary edema. So a predisposing condition is already there. One it is already there. Then renal failure,
Yes, sir.
CKD, right?
CKD. Mild renal dysfunction.
So that is also that can lead to fluid overload.
And also causes.
That can cause a pulmonary edema. Then bronchial asthma.
Yes, sir. Known
That
case
is
of
also
asthma.
there.
That is
So
also
that is
there.
but wheezing,
Because
wheezing
is
wasn't there.
there.
Okay. So right now let's forget about bronchial asthma for the time. With no wheezing.
Yes.
Okay. Then what else is there?
Then his surgeries were done for cholecystectomy and hernia, and cataract surgeries were done. Apart from that, left shoulder dislocation.
Okay. So these are the
Comorbidities which he is having.
comorbidities. So your primary, based on your this thing, background history, also diabetic.
Diabetic also is diabetic.
Okay. Even diabetic ketoacidosis can cause a acidotic breathing. If suppose that ABG had shown metabolic acidosis, you would have thought in terms of
High sugars
high
and
sugars and diabetic ketoacidosis, causing that too small breathing and all. So the first impression seems more like a
cardiac event.
cardiogenic pulmonary edema. So you have given Lasix dose, how much you gave? Or?
Lasix was initially the stat dose followed by infusion was started. Stat dose of 60 mg was given, followed by 6 mg per hour.
Okay.
That is for the fluid overload status. Right now, coming to the events leading to this, events leading to his.
What about the ABG? What about the creatinine? Was there a worsening?
Creatinine was 2.86. Previous our lab value was 2.7.
7. So not much of a
change.
Okay. An endogen dysfunction, it's not there. Only the cardiac pulmonary edema is only.
Usually, if we consider this as the in the events, actually, we got to know that the patient has missed the last 2 days his antihypertensive tablets.
So that we'll discuss in this thing. So this is basically a hypertensive emergency.
Hypertensive emergency.
Which has led to pulmonary edema.
Hypertensive emergencies could be of like a hypertensive encephalopathy, intracranial hemorrhage, preeclampsia, acute pulmonary edema.
Depending on which organ is involved, it can vary.
Yes, sir.
So at this point,
And aneurysm, aortic dissection, these all can be the hypertensive emergencies we have. At this point of...
if brain is involved, it's hypertensive.
It can be hypertensive encephalopathy, IC bleed or focal neurological deficit.
Okay, stroke and everything can happen. If heart is involved?
If heart is involved, we are considering it to be MI-ish, myocardial infarction, or the other thing is pulmonary edema, left ventricular failure causing pulmonary edema. If kidney is involved, we consider to be again renal dysfunction will be high. And the other thing is uterus. Uterus is involved, then preeclampsia can be in the pregnant female. If uterus is involved, then there would be the basilar.
So the treatment varies depending on what hypertensive emergency it is. The treatment really varies. Okay. For in this case, what do you suggest? In this
case, we are having a cardiac vascular system problem, which is like the left ventricular failure causing the pulmonary edema. So, depending upon this, the choice of treatment would...
In the meantime, you would have taken the ECG also, right?
Yes, a 12-lead ECG was taken. There were LVH with strain pattern was noticed, but there is no any acute STT changes with respect to previous ECG.
Okay, LVH means ECG. What all things you look for? Like?
We've seen V2,
SV1 plus RV6 more than 35.
35.
Small box is one criteria. There are several other criteria also. Okay. coronal voltage criteria, so also Colon index. So many things are there. Okay. So right now probably you would have started with NTG.
Yes, sir. The choice of hypertensive emergency causing pulmonary edema is nitroglycerin infusion.
Okay. So the patient didn't have any pain as such, right? No chest pain or anything.
No chest pain. There was no history of any chest pain, no history of sweating.
Okay. There was a chest pain, we would have given some morphine also.
Morphine, and even beta blockers also is indicated in the.
Okay. So the shortness of breath, you can elaborate. NTG, what dose did you start?
Sir, NTG we start with 2 to 10 mg per hour maximum.
NG or?
Mg per hour. NTG is 10 to 20 microgram per minute. 10 to 20 microgram per minute, and maximum we can go till 200 microgram per minute.
Yeah. That is good. More than 24 hours you don't.
We can, because of tachyphylaxis and tolerance. The patient.
Tolerance you won't continue the thing. Okay.
Regarding the shortness of the breath.
Now we can just elaborate. We have done the necessary things to stabilize this case. Now we can move on to secondary survey, the elaboration of the shortness of breath. All right.
Shortness of breath, the patient.
So this being a shortness of breath, you'll have to address the HOPC in terms of the onset, duration, intensity, progression, previous episodes, any aggravating relieving factor, and associated symptoms. All these things we want to know.
Shortness of
that
breath.
That is your chief complaint right now.
Yes.
All right.
Onset of the shortness of breath was 3 hours ago.
Okay.
And progression was the patient had a sudden onset of.
What was he doing at that point of time?
He was climbing stairs.
Climbing stairs. Yeah. Okay. So apparently asymptomatic patient skipped 2 days medications. Now climbed stairs and all of a sudden started developing breathlessness. Oh.
And grade 4 of shortness, grade 4 and which even on lying down he is having shortness of breath right now.
Okay, which gradually
progressed.
Progressed.
Previously baseline is 3. He can only do his baseline is 2. He can go out of his house, but he cannot more than 100 meters he feels the breathlessness.
Oh. Okay. Then why say listening on exertion class 2 or something?
Class 2. Baseline is class 2, which progressed to class 4.
Class 4 or after climbing few
stairs.
All right. Okay.
Then onset progression, and then aggravating factor was his shortness of breath aggravated on exertion. We can say it as exertion. And also the missing of the medication, hypertension has caused this.
Okay.
No.
Immediately after that, he was brought here or gone to some other hospital?
He was brought to our hospital immediately. And we cannot comment on PND or orthopnea because very short.
What about the associated symptoms?
Associated symptoms, no any history of fever or no history of sweating, no history of chest
associated
pain.
Symptoms, you have to address all the 8 systems. So first of all, the CVS.
Cardiology.
And the CVS and RS goes first.
Yes. Cardiology wise, there is no chest pain, there is no sweating, there is no palpitation.
No sweating was there? Okay.
No sweating, no palpitation.
Okay. Ideally, with this much of a shortness of breath, pulmonary edema, and we actually expect this catecholamine. So we expect sweating and we expect tachycardia and all. But this was 87 per minute.
Yes. I think by the time
was he already on some beta blocker? Or?
Yes, sir. For hypertension,
maybe because of that,
beta
his
blocker.
heart rate has not gone up. Okay.
Yes.
Because patient is in distress.
Distress, yes.
So we expect these things to go up.
So sweating as in sudden, at that onset of sweating was not there. He was having
okay.
Sweat. Cardiology wise, these are the palpitation, sweating and chest pain was
dizziness,
not there.
No
dizziness.
Okay.
Then respiratory wise,
any shortness of breath, cough.
No history of any cough or wheezing.
Nothing was there.
Next coming.
Expectoration, nothing.
No cough.
Then their priority goes to CNS and musculoskeletal. Because even CNS issues can cause breathlessness, motor neuron disease, Guillain-Barré syndrome, even snake bite progressing, causing diaphragmatic palsy and all these things. So, CNS.
Patient was conscious,
oriented.
He had no any.
Headache, no neck stiffness, nothing.
Nothing.
No weakness, nothing.
No focal neurological deficit.
Nothing. Okay. Musculoskeletal, any body pain, muscle pain,
Just the
weakness,
accessory is
paralysis.
feeling the chest paining because of the accessory
Okay.
muscles used.
No recent trauma, nothing. No weakness, peripheral
No
muscle
weakness.
weakness is not there.
No weakness.
Okay, so right now in that case you have ruled out a GBS.
G.
Okay.
Yes.
So all these things are important, especially when you are giving your marker, because all these they have a checklist with them and they'll be ticking whether you have asked questions pertaining to CNS, musculoskeletal, GIT, genitourinary, CNS, the CVSRS, all these things you'll be looking at. Okay, then
Then next coming to the genitourinary GIT, we can say there's no history of vomiting, diarrhea.
no vomiting, diarrhea, no abdominal distension, abdominal pain, like normal stools, right? Genitourinary, no change in urine or urination.
No burning mixture.
Urine output is there, preserved, right?
Preserved.
Okay.
No sudden change, reduced urine output for the last few days.
Okay. If urine output wasn't there, then probably
We can consider nephrogenic cause of
it may require
hemodialysis.
dialysis. Okay, in this case, because even if you give Lasix, if output is not there, there's no point. Then skin, any issues?
Rashes.
Nothing. No rashes, nothing. Is there on the mucosa? No issues at all. Okay. Then any oncology things? Any miscellaneous?
Not a known case of any
loss of weight, loss of appetite?
No loss of weight in the last few weeks.
Okay. Any lumps or bumps in the body? Evening rise of temperature? Nothing is there.
No history of fever.
Anything more to add on to this HOPC?
Events leading to it would be part of HOPC.
Okay, that's all.
Yes.
Okay. Past medical history, we have already
Discuss the
discussed the
comorbidity.
co-mobs. Okay. Surgical history, nothing.
Surgical history was
CABG,
the post CABG, post cholecystectomy and inguinal hernia.
Any recent travel?
Nothing.
What is he doing? What is his job?
Right now he's
social history, social sexual travel history, like
right now he's a retired person. He just stays at
retired, married, and okay. So what is your gone out at the end of your history? What is your pulmonary edema, right?
Yes.
So pulmonary
Accelerated hypertension.
hypertension.
Hypertensive emergency. It's a hypertensive emergency. The part is the pulmonary edema, left ventricular failure.
Okay. So after giving all these things, after the primary survey or intervention, did he improve?
Regarding the hypertension part, the interventions which we did were putting him on BiPAP, starting with the Lasix, giving a bolus and the infusion dose, and after that giving the antihypertensive medication. As it's a hypertensive emergency, we target to reduce the BP 25% in the first 1 hour. And
some books they have written 20%. Up to date or something. I think so. Just clarify. 20%, not more than 20% reduction in
first 1 hour.
First 1 hour.
So that the perfusion of the other organs wouldn't be affected if it goes hypo.
Yeah. That is one thing. Systemic examination, anything?
In systemic examination, like pertaining to the respiratory system, basically, on auscultation, the crepes were present bilaterally all over the chest. And there were no any dilated veins or any inspection wise. And in the cardiological S1, S2 heard, there are no any added sounds.
S3, S4 wasn't there.
Yes, it wasn't. Not a heard.
You couldn't appreciate.
He can't appreciate. So from the emergency point,
JVP is not elevated.
JVP is not.
Okay. What about the pedal edema? Was it there?
There was bilateral, no pedal edema.
No pedal edema. No murmurs as such. No MR, no nothing.
No.
Okay. And the CVS other systems are all fine.
Other systems.
What about the lab values? Did it come?
Yes, sir.
We have already taken in C itself. We have drawn blood.
Yes, sir. In the initial labs which we got, we sent for cardiac enzymes, NT-proBNP, so all labs, and even chest X-ray. So in the cardiac enzymes wise, HS top T was negative 0.024, and CKMB was 3.25, which is in the normal limit. So, and NT-proBNP was 1175.
So a bit on the
It looks
side.
there was no elevated cardiac enzymes in the first, but we the advised for the 0-6-12 monitoring of cardiac enzymes to record if there was any cardiac event.
Okay.
Apart from that, the WBCs were only 4.2, and CRP was 0.89. So there was no any infective reason.
Sepsis part is out.
Sepsis part is out, and hemoglobin was 11.5. So even
anemia is also out. Thyroid.
Which thyroid function
Normally
test
you don't
hasn't
send
come.
in sick cases and all. You usually don't send thyroid. You won't be able to appreciate what exactly.
Because
So by the end of your history and examination, acute pulmonary edema is your this thing, and you have started NTG, gas infusion and Lasix, and probably handed it over to.
we titrated NTG as per the BP. Once the BP fell 20%, we had reduced the dosages of the NTG, and we even started his old antihypertensives. One dose of oral antihypertensive was given to sustain reduce the BP, and handed it over to the cardiology department for admission. We advised admission for this patient.
So what are the hypertensive emergencies that you like? Various hypertensive emergencies.
Various hypertensive emergencies are hypertensive encephalopathy, intracranial bleed, acute.
So what drug will you give in each?
In hypertensive emergency, we prefer using labetalol, and in IC bleed also labetalol.
Except for cardiac, this thing labetalol fits almost all
Every
of the
other
thing.
case.
Other drugs usually used like are SNP.
Yes, sir.
SNP, like we don't use it here.
Okay.
But in the theory wise, they have mentioned SNP and all.
Yes. Basically, sodium nitroprusside is given in we can give it in pulmonary edema.
But some side effects are also there for SNP.
Yes.
We don't use it here.
Okay.
If it's a pheochromocytoma and all.
For that, we give phentolamine. And for pre-eclampsia also, we prefer labetalol. Eclampsia, MGSO4, pre-eclampsia, labetalol itself. Okay. And second line would be hydralazine.
Okay.
For nitrates would be given in cardiac ischemia and pulmonary edema.
Okay.
And nicardipine also can be used in hypertensive encephalopathy. Our first line being labetalol, second line being nicardipine. CCBs can be given.
Okay. What else is there? Any other?
Yes. The patient eventually was
He improved
on the NTG, and once the hypertension is reduced, the patient actually had multiple admissions of congestive heart failure. So his drugs were optimized, and he was discharged by the cardiology after 2 days of admission.